In the second line setting, we mostly use ramucirumab plus paclitaxel, so we prefer the combination over the monotherapy. However, ramucirumab monotherapy still have still plays an important role in patients who do not want to have cytotoxic agents, or in patients who have contraindications against paclitaxel or irinotecan. There is also a group of patients where we sometimes try monotherapy. If these in this group are consists of patients who have low remission pressure, so a very minimal metastatic disease, like small lymph nodes only, where you could try with the monotherapy. Overall, in the most cases, we prefer the combination of paclitaxel and ramucirumab over the ramucirumab monotherapy.
So the other issue that comes up with the use of ramucirumab is that the drug also did get regulatory approval by itself as a second-line treatment. The trial of ramucirumab versus best supportive care without chemotherapy was also a positive trial, indicating modest improvements in progression-free and overall survival. But ramucirumab alone really doesn't induce responses, and it's at best a stabilizing drug. Because second-line patients are often going to be more symptomatic with an advancing disease burden, the preference would be to combine ramucirumab with an active chemotherapy drug, paclitaxel. We saw a response rate approaching 30%, which is clinically meaningful. Ramucirumab alone achieved no greater response than placebo, although there was more disease control, more disease stabilization. So there would be rare, if ever, circumstances that I would give a patient ramucirumab alone. The argument that, oh, we can give this drug to the sicker, poor functional status patient, that's the patient that's not going to benefit because there's no response. We might consider in some patients, if they're on paclitaxel ramucirumab and they develop cumulative taxane toxicity, neuropathy, and other issues, and they've shown response, that we might consider ramucirumab maintenance therapy later, but that would be exceptional. Also, another consideration now is, and we'll talk about this in the discussion of adjuvant treatment, is the standard preoperative chemotherapy for gastric cancer now is the FLOT regimen, which is infusional 5-FU oxaliplatin and docetaxel. So increasingly, patients will have had previous exposure to a taxane. So when there is recurrence, we could argue that the patient has already seen a taxane, and perhaps combining a taxane with ramucirumab as a salvage option may not be optimal. We were particularly concerned in patients that have disease progression within less than 6 months of receiving a perioperative or adjuvant treatment. So based on this, there was a recent clinical trial conducted in Germany where they looked at, it was a randomized phase 2 trial. It's only been published in abstract form, but they compared in second-line treatment paclitaxel ramucirumab versus FOLFIRI plus ramucirumab. It's a phase 2 trial, but it did indicate, and many of the patients on this trial had received previous taxane as an adjuvant or neoadjuvant treatment. And the trial did suggest a higher response rate for the FOLFIRI ramucirumab versus paclitaxel ramucirumab. And the NCCN guidelines, again, acknowledging that many patients will now be getting a taxane as part of their preoperative or adjuvant treatment, that we need, we don't really expect that the benefit of ramucirumab is a chemotherapy-dependent one. We really think it's a biologic drug that enhances the efficacy of chemotherapy, and we don't expect that benefit to be limited to a taxane. So based on this, the NCCN guidelines have endorsed in appropriate patients, particularly if they had recent taxane exposure or progression on a taxane, to consider 5-FU irinotecan FOLFIRI ramucirumab as an appropriate partner for a second-line treatment, which makes sense clinically.
In Western countries, FLOT is increasingly being used as a perioperative treatment as well as first-line treatment. In Japan, S1 plus docetaxel has become the new standard of treatment for stage 3 advanced gastric cancer as adjuvant therapy. And in Asia, DOS, docetaxel, oxaliplatin, and S1 triplet regimen, including taxane, is increasingly used as a perioperative chemotherapy. Please refer to Prodigy trial. If taxanes are already being used in previous therapy, I believe that irinotecan-based therapy should be used as a second-line setting. And of course, it is reasonable to add ramucirumab to it. It is a strategy that is already widely used in colorectal cancer.